Hi, everyone. My name is Amy Olex, and I am one of the leads to the Immunosuppressed and Compromised Clinical Domain Team. I'm from the Wright Center for Clinical and Translational Research from Virginia Commonwealth University. Also on the leadership is Dr. Roslyn Mannon out of the University of Nebraska Medical Center, and Vithal Madeira from Palila Software. The ISC team meets every other Friday at 11 a.m. Eastern, and our next meeting is coming up this Friday on April 2nd. So you're welcome to join us if you're interested. Our team has over 35 active members from across the United States and Canada. We have many university academic centers, as well as industry and nonprofits members in our group. So our mission is to gain a better understanding of how COVID-19 affects patient populations with suppressed or compromised immune systems. We currently are operating under a level 2 approved DOR for de-identified data. And our focus research areas are comparing the incidence of COVID-19 in subsets of the ISC population to those without a compromised immune system, looking to see if there's an association between ISC populations and severity of COVID-19, as well as investigating if the type, class, or duration of an immunosuppressive drug correlates with severity of COVID-19. And finally, characterizing the outcomes of ISC patients after treatment for COVID-19. So our team is structured into currently 9 subdomain teams, and we welcome new teams if you're interested in pursuing research on the immunosuppressed or compromised population. So our subdomain teams are self-organized, and they each lead their research in their specific domain. So each subdomain team contains a clinical informatics and epidemiology or statistics lead. And there's multiple projects going on within each subdomain. So each team is in a different spot as far as development-wise goes in the overall ISC team. So we have some teams that are relatively new and just starting to form, like kidney and cardiology and glomerular. And then we also have other teams such as autoimmune skin disease, who's working on their initial cohort identification, the multiple sclerosis and rheumatoid arthritis teams are midway in the process, gathering descriptive statistics of their cohorts and performing outcome analyses. And then our most advanced teams are the chronic immunosuppression, HIV, and solid organ transplant teams, all of which have 1 or more manuscripts that are currently in preparation and being ready to be submitted. As the ISC lead, I do a lot of the communication, coordination, organization, and facilitation across all of our subdomain teams. This includes helping to onboard new team members, get new teams started up, as well as setting overall priorities and goals for all of our teams to reach for, as well as controlling data access for our members. But we also do this not just within our group, but we also coordinate and communicate with other teams outside of ISC, such as other N3C work streams like the governance team and data ingestion, as well as clinical scenarios, and other organizations such as NCATS, Palantir, and some contributing institutions, as well as other clinical domain teams. But so as lead, I don't necessarily do all of this alone. Many of our team members also do a lot of these functions and are involved with many different N3C groups. And they also serve as clinical and informatics subject matter experts for various initiatives. For example, members of our HIV team are working with data ingestion and Palantir to figure out the harmonization of lab values. So working with the N3C data has presented a lot of challenges, specifically informatics challenges for our team that we've been able to work together and get around. Data coming in from 47 different sites using different data models that are gone through rigorous quality checks, mapped to the OMOP data model, to give us over 5 billion rows of data to sort through to answer our clinical questions. So a lot of times new members that join our team or new teams that are just starting up, their first question is, well, where do we start? So as a team, we put together just a little list of lessons that we've learned, things that are very helpful to do and think about when you're first starting up. For example, be familiar with the OMOP Common Data Model or work with someone who is. That's very important. Also, taking Palantir Foundry training we found is very helpful, even if you're not planning on analyzing the data and digging into it. It's helpful to just know how to maneuver in that platform. And understanding N3C's COVID-19 phenotype, because this determines which patients and N3C determines to bring into the enclave. Getting to know data origins and pre-processing, such as a submitting institution's data model, how they do date shifting, what data elements are available, that kind of thing can all have influence over how you design your study. Accounting for site-specific date shifting is important. And we found that performing site-specific analyses, as well as our global overall analyses, are very helpful to understand how valid our results are. Recently, we've discovered we need to ensure that published data sets are in fact frozen. And our team is right now working on discussing that and coming up with a model that all of us can use to ensure that we do this consistently. And then finally, spend time on your cohort identification, because this is the foundation of your study, and it's very important to get right. So in the ISC team, cohort identification starts with the process of identifying your clinical question and characterizing your ideal cohort. And your clinicians and subject matter experts are gonna take the lead on this. And within our team, we also have a form that you can fill out to kind of help with the process and the to organize your thoughts around what questions you're asking and what cohort you need to extract. And so this includes identifying inclusion and exclusion criteria like diagnostic codes or medications, and identifying which subgroups of your cohort you want to be able to analyze. Of course, COVID positive and negative is an important one, but also you could look at the condition severity, social economic status, that kind of thing. So for the example question above, do disease modifying therapies for multiple sclerosis impact the severity of COVID-19? This is one question the MS group is looking at, and we've chose to characterize our cohort using diagnostic codes and medications, and break our cohort up into COVID positive and negative, of course, as well as the severity of the MS. So the next thing, once you get your clinical characterization together, is to develop concept sets. And data liaisons are going to be very valuable at this step because they are very familiar with the OMOP data model. And if you are in a subdomain team, you already have a data liaison from N3C assigned to your group to work with you. So this is done through OMOP and Odyssey tools such as Atlas, and it can also be done in the N3C enclave using the concept browser. And here you see an example of a concept set for the MS ICD-10 diagnostic code, G35, where it's just a list of terms. And this is going to help take your clinical characterization of your cohort and bring it over into the N3C enclave to be able to pull those patients out. Next, once you have that developed, it's time to develop and implement your computational phenotype, extract cohort demographics and outcomes, and run your analyses. And throughout this process, your logic liaisons or your informaticians and data scientists and your statisticians are going to take the lead to be able to actually implement and ask your questions in the database. And all of these steps, including developing concept sets, can be done in the Palantir Foundry interface, which is the N3C enclave. And also, I just want to point out that this whole process of cohort identification is very collaborative, iterative, and the foundation of any research with N3C. So while I show it as a linear pipeline, it actually iterates over many steps where we explore the data, we go back and refine our concept sets, refine our clinical cohort. And so all of our clinicians, data liaisons, logic liaisons, and statisticians are involved in almost every step of this process. Another thing that I mentioned is the COVID-19 cohort. And so the N3C defines, has a definition or a phenotype for COVID-19. The ISC team tries to use the N3C phenotype for COVID-19 in all of their projects. However, depending on the question or specific project that you're working on, it may need adjustment. So we always try to keep that in mind when we're coming up with new questions and new projects. And finally, I just want to point out that one of the goals of the N3C Enclave is to provide a large set of COVID positive patients for research and to improve patient care. And so the N3C Enclave is providing some of the largest cohorts of immunocompromised and suppressed patients in the literature to date. And here's just an example of the 4 teams that you're going to hear from today, with solid organ transplant having over 4,500 COVID positive patients, HIV with over 8,000 COVID positive patients, chronic immunosuppressed patients over 12,000, and multiple sclerosis patients, we have over 17,000 COVID positive patients, which is really great. And we're super excited to be able to dig into this data. So without further ado, I'm going to pass it off to the solid organ transplant team, which is led by Dr. Rosalind Mann.
Hey, Amy, before you go, there's a question in the chat that you might want to answer now. And the question is, will you be able to share the form that the group has to help start research?
Yes. And some of our team members developed that form, so we can certainly share it.
And
thank you, Roz.
I think that's, there might be another question. Nope, the other question was me trying to get into the room. So if you can put the slides back up. I was in the waiting room for a little bit.
Whoops. I stopped sharing screen, sorry.
No worries. Thanks, Amy. I'm Roz Mann, I'm the team lead for the subdomain solid organ transplantation, and I'm a transplant nephrologist at the University of Nebraska Medical Center. And I won't spend most of the time presenting or talking today. I'd like to the rest of the team who've done a tremendous amount of work. And our goal of this subsection is to identify the incidence and severity of COVID-19 disease in the solid organ transplant recipient. And to date, there have been quite a number of reports. Most of them are single center data, some registries that are quite limited, but no one has the level of size and volume of information as NC3. And so I think the group of us working in this area really feel honored. I have to say it's great to see more cases added, although today was a very depressing day to hear the CDC's comments. Our goals are to define the impact of patient demographics, type and timing of transplant and immunosuppressive therapy on COVID-19, and specifically looking at outcomes of COVID-19 based on the type of solid organ individuals have. That's been difficult to do in other data sets because of the small sample size. To determine the impact of SARS-CoV-2 infection on allograft function and patient and allograft survival. And finally, identify approaches to antiviral therapy and their impact on COVID-19 disease in this patient population. Next slide. So we're going to hear from 3 different individuals today. The first project is that we call it the cohort of solid organ transplant and COVID-19. This work was submitted as an abstract. It received a Young Investigator Award to the Cutting Edge of Organ Transplant annual meeting in February, and is an oral presentation pending in June 2021 at the American Transplant Congress. And we're in the process of drafting the manuscript. We do have to redo a bit of a data analysis and need the immunosuppressive data, specific data for each of these patients, but these were data based on phenotype 2. And that'll be presented by Gaurav Agrawal. The second project is predictors of major adverse renal or cardiac events known as MARS in solid organ transplant with COVID-19. And that'll be presented by Amanda Vinson. And finally, the third project will be the effect of cytomegalovirus. And that is a manuscript pending and has been submitted to the publication committee. And the third is effect of CMV on COVID-19 outcomes in solid organ transplant, effect of CMV PCR on outcome. So Gaurav, why don't you go ahead and talk about this project?
Can you hear me? Thank you, Dr. Manon. Thank you for allowing me to be part of the SOT subgroup. This is very exciting. Our first project was to define the solid organ transplant COVID-19 positive cohort. The literature on COVID-19, as Dr. Manon alluded, that infection, COVID-19 infection in solid organ transplant suggests there is a significant increase in mortality. We compared the COVID-19 positive to negative controls, and this was done in November when we had the phenotype 2 data. Since then, the data has been changed to the phenotype 3, which was in December, and we lost the COVID-19 control cohorts. The phenotype 2 at that time had data matched for age, gender, and ethnicity. Nevertheless, we were able to get that cohort, and we compared the COVID-19 positive patients with negative controls. Next slide, please. Solid organ transplant patients with negative controls. We had over 2,000 patients at that time, and you can see over this course of 4 months, now we have more than 4,000 patients, so we have doubled our cohort. And we compared these with 16,000 controls. So we found that COVID-19 positive patients were slightly younger, more likely to be non-white, and more likely to have a kidney transplant. Lung and liver transplant made smaller portion of the infected patients. As seen in general population, hypertension, diabetes, coronary artery disease were more common in the SOT COVID positive patients. CKD and peripheral vascular disease were more likely in the COVID-19 infected patients. Not shown here, but following the COVID-19 diagnosis, 13.7% of the patients suffered major cardiac events, and about 4% had graft rejection. 3.4% had graft loss over this 1-year study period. The key missing piece of data is immunosuppression, and we really need assistance with immunosuppression code set. This will really, once we have frozen the data, we are going to redo the analysis, and hopefully with immunosuppression, we'll have something good to talk about. Next slide, please. Amanda Vinson is going to talk about the MARS outcomes next.
Hi, everybody. Thank you for the opportunity to speak here today. And as Gaurav and Dr. Manon alluded to, I'm also quite grateful to be part of this group. So I'll talk about our study looking at MARS, or major adverse renal or cardiac events. So for the purposes of our study, we define this as acute kidney injury with or without the need for dialysis, acute myocardial infarction, angina, stent occlusion or thrombosis, stroke, transient ischemic attack, congestive heart failure, or death from any cause. This is a pretty typical definition used in the literature, although the definition does vary. We know that MARS is a major cause of morbidity and mortality in patients following solid organ transplantation. However, interestingly, despite it also being a complication following COVID-19 diagnosis, there are no earlier studies of MARS in solid organ transplants who have been diagnosed with COVID-19. In addition, we know that older males with COVID-19 in the general population are at higher risk of poor outcomes, but this has not been rigorously explored in the solid organ transplant population. And in fact, when it has been looked at, there does not seem to be a signal that there's a sex effect on outcomes. Next slide, please. So we wanted to study this a little bit more rigorously, given how large our sample size was, to see if we could actually highlight a sex-dependent impact on outcomes, specifically on MARS. So in this study, we're looking at the incidence of MARS following diagnosis of COVID-19, based on sex, based on, again, substratified by age. What you see is that in the non-solid organ transplant population, or the general population, there is in every situation a higher risk of MARS in males compared with females. And this is highly statistically significant when you're 65 years of age, mid-age, or younger. Conversely, when we look at the solid organ transplant group, what you see is that really only in mid-age are males at higher risk than females of developing MARS. What you can appreciate, though, is that clearly solid organ transplant patients are at a much higher risk overall for MARS than our non-solid organ transplant patients. Next slide, please. Now, this is highlighted again in this time to event analysis. If you look at these survival curves, you can see that by about 20 days post-transplant, there's a clear separation of survival curves based on sex age strata. Whether you're male or female, if you're older age, you have the highest risk of developing MARS. If you're young, you're relatively protected from MARS. Again, it does not matter if you're male or female. But in that middle age green category, you can see that again, males have, or that in this situation, males have a higher risk of developing MARS than do females. And again, this is clear. This is clearly evident by about 20 days post-transplant. Next slide, please. So when we stratified the impact of sex by age category, what we saw is that what we expected in the non-solid organ transplantation population, this has been shown many times, is that females were lower risk for MARS than were males. So this is not new. Interestingly, though, what is new is that when we looked at the solid organ transplant population, there was no increased risk of MARS in those who are young or in those who are old. And really, all we see is a signal for increased risk in males compared with females in that mid-age category. And the thought is that maybe this reflects a differential effect of immunosuppression in males and females over the life cycle. So this is quite novel. Next slide, please. So this led us to look at a number of secondary outcomes, again, looking at the relative risk of in females versus in males. Again, in the solid organ transplant population, as you would expect, females were lower risk for our 5 secondary outcomes: MARS, mortality, MACE, or major adverse cardiac event, AKI with or without requirement for renal replacement therapy, and severe COVID. Again, this is not new. This is something that's been seen in earlier studies. Interestingly, though, when we look at the solid organ transplant cohort, we see that females were overall lower risk for MARS, overall lower risk for mortality, and overall lower risk for AKI renal replacement therapy. But there is no sex disparate difference in the outcome of MACE or in COVID-19 severity. Next slide, please. So finally, as was mentioned, our cohort of 4,510 solid organ transplant patients is the largest by over 4-fold. The largest preceding COVID-19 solid organ transplant cohort published to date has an N of 1,013. In our cohort, 1,802 developed the outcome of MARS, which is 40%. What we saw is that solid organ transplant overall is a risk factor for MARS after developing COVID-19 with a hazard ratio of 1.18. We saw, as expected, that this risk increased with age, and we saw that overall in our cohort, while females were lower risk than males, this was driven completely by that middle age category with no sex disparate risk in those who are younger or older, in the younger or older categories.
My name is Raina Patel. I am an adult infectious diseases and HIV physician and researcher based at the University of Washington. I too want to echo 2 things. One, we feel so fortunate to be working with the N3C data. As you will see, this is the largest cohort for people living with HIV that we're going to be putting forth data with. And 2, I also want to thank the leadership in the immunosuppressed compromised group, particularly Amy and all her amazing organizational skills that, as you can see, have allowed us to be quite productive. So now I'll shift to telling you a little more about our HIV team, and 2 of our colleagues will go on to present more detailed data that they've been working on. Some of our initial research aims have focused on determining if incidence of COVID-19 test positivity or severity of infection is higher among people living with HIV versus those who are not living with HIV, adjusted for various covariates. We also are interested in looking at racial and ethnic disparities that may exist in the COVID-19 outcomes as well as infection rates. So some of you may be already aware that there is a really large racial ethnic disparity in the HIV epidemic. And then when you layer on the COVID epidemic, where we also know racial and ethnic disparities exist, do these confound further? And Jessica Islam will be talking about that next for her analysis. We are also interested in looking at if incidence of COVID test positivity as well as severity of infection differs among different immunocompromised populations, along with many colleagues who have already spoken and will speak next. And we've started looking at this, comparing people living with HIV against solid organ transplant individuals. Some of the future directions we're interested in taking is seeing if duration of HIV infection or HIV treatment influences the risk for incident or severe COVID, if certain antiretrovirals such as protease inhibitors may have any protective effects on progression to severe COVID infection. Next slide. Our larger team thought it may be helpful to explain to the group how we came about determining the HIV cohort, so that you others who are in the audience may be able to learn from what we learned, perhaps the hard way. So HIV can be, we've focused on 3 domains, major domains, or tables, data tables, to define HIV cohort. And if you were to only look at ICD coding for conditions, then you would only be capturing what we believe is the universe of people living with HIV and N3C, only about 80% of those. So that's meant to be that blue bubble. And there are, in fact, more individuals who have a signal for an HIV-specific medication. So I just want to clarify that not all HIV-specific medications are for treatment. Some of them are for prevention, what we call pre-exposure prophylaxis or post-exposure prophylaxis. With the help of Vithal and others, we've been able to track those to exclude those individuals. And then the third domain that we've looked at is laboratory parameters that are specific to HIV. And interestingly enough, that there's a lot of overlap between HIV condition and labs, but not as much between HIV condition and drugs. So when we pull, the table takes you through various algorithms that we use to eventually get at our cohort definition. The point being here that it helps to triangulate how to define your cohort in multiple ways, much the same way that the multiple sclerosis group has done. Next slide. At this point, I'm going to hand it over to my colleague, Jessica Islam, to tell us about her work looking at racial ethnic differences in people living with HIV. Thank you.
Is Jessica on?
She was,
She was on and needed to be let in as a panelist.
Yes,
Thank you.
Yay. Working.
okay, I'm so sorry about that, everyone. Thanks for bearing with me. So yes, as Rena mentioned, racial and ethnic disparities among people living with HIV and COVID-19 positivity is an important public health issue. These data, just as a quick background in terms of where this has been shared, this was shared at CROI, which is the biggest HIV meeting internationally, and it was presented, I believe, last month, and it was well received. So excited to be sharing it with the N3C group. Very quickly, we used data collected from adults over the age of 18 years, collected between Jan 1st of 2020 through January 29th of 2021, and we leveraged the phenotype 2 data for this analysis. And in this table presented here on this slide, I'm focusing specifically on the population of adults living with HIV. In total, we observed, based on this time frame, about 17,820 people living with HIV in the N3C. And to give some quick stats, about 3/4 of people living with HIV were 30 to 64 years of age, about 68% were men, and about 21% had a Charlson comorbidity score of 3 or above. Next slide. Here again, we're focusing on people living with HIV and evaluating racial disparities in COVID-19 positivity among this patient population. And as you see here, summarized in this figure, COVID-19 positive people living with HIV were more likely to be non-Hispanic Black and Hispanic and conversely, less likely to be non-Hispanic white when we compared to people living with HIV without COVID-19. Next slide. And this slide is based on the multivariable logistic regression analyses, which asked the same question, but through this analysis, we were able to adjust for several covariates, including age group, sex, and a modified Charleston-Deyo comorbidity score, excluding HIV status. And to orient you a little bit to this slide, the one here represents, or this dotted line represents the null value, meaning that there's no association between a racial ethnic category with COVID-19 positivity. So anything above this line depicts elevated odds. So after adjustment for our covariates, we observed elevated odds of COVID-19 positivity across all racial groups when we compared to non-Hispanic white people living with HIV. And those are just a quick summary of my results. And with that, I'll yield to Jane.
Hello, thank you so much, Jessica. And so I'm just going to move on with our presentation here. This is also presenting in a talk at CROI in early March. And then, so in this particular study, we sort of compare risk of COVID-19 related hospitalization by the different immunosuppression group, including people with HIV and solid organ transplant recipient from January 2020 to February 2021. So as you can see, the primary outcome here is looking at the hospitalization, and then we included total of over 500,000 patients with COVID-19 in N3C. And the participants' characteristic was well described by Jessica's slides, and the median age for the population is about 46. And people with HIV are more likely to be male and non-Hispanic Black. And solid organ transplant patients were more likely to be older and non-Hispanic White. So people with HIV and solid organ transplant are also more likely to have more than 3 comorbidity conditions compared to the others. So in this slides, we show that compared to people without HIV or solid organ transplant, people with HIV have over 2 times, roughly about 2 times higher risk of hospitalization, and solid organ transplant recipients have about 2.6 times higher risk of hospitalization. And this increased risk were primarily driven by the high burden of comorbidity in both groups. And after control for number of comorbidity as well as comorbid condition, including liver disease, diabetes, cancer, and renal disease, the association between immunosuppression group and the hospitalization attenuated, but they were still significant. So in particular, people with HIV and solid organ transplant were over 80% and over 90% higher odds of hospitalization compared to the rest of the N3C population. Next slide, please. So this is a Kaplan-Meier curve of time to hospitalization among people who were not admitted to hospital at the time of COVID positive test. So compared to people who were not immunosuppressed, which is denoted in the yellow line in this graph, we saw that people with HIV denoted in the black line here, and then people with solid organ transplant denoted in the gray line here, and people with both HIV and solid organ transplant denoted on by the blue line here have faster time to hospitalization and a higher proportion admitted to hospital. So the majority of the event happens within the first 21 days of COVID-19 positive test. And by 21 days, about 17% of people with HIV, 30% of people with solid organ transplant, and nearly 40% of people with both HIV and solid organ transplant were admitted to the hospital. And in the cost regression model, compared to people without HIV or solid organ transplant, people with HIV and solid organ transplant and people with both had about 21%, 55%, 67% increased hazard of hospitalization within 45 days, respectively. And this increased hazards were independent of their social demographic, their comorbidities, and the study site. And in a sensitivity analysis restricted to 21 days after COVID-19 positive, you a very similar result. Next slide, please. So we further assess the risk of hospitalizations by particular comorbid conditions among people with HIV in a series of logistic regression models. So as shown in this forest plot, people with HIV with history of cardiopulmonary or renal disease had higher odds of hospitalization with COVID-19. And all associations were independent of demographic characteristics and study site, as well as the total number of comorbidities. So to our knowledge, this is the first study to compare risk of hospitalization among people infected with COVID-19 by people with HIV and people who were solid organ transplant recipient. And the N3C database is the reason that we were able to conduct this study. So as we know that previous studies were unable or lack of statistical power to assess the risk of severe COVID-19 among people with HIV. And the current CDC guideline has prioritized vaccination among solid organ transplant recipients. However, there is no specific guideline among people with HIV due to the limited data in the field. So our data really show that people with HIV and solid organ transplant recipients are actually have comparable risks of developing severe outcome. And these results, we think, have great clinical significance and might be able to provide further justification for vaccination prioritization and early treatment among people with HIV. Thank you.
Hi, I'm Katie Anderson. I'm at the intersection of the chronic immunosuppression group in the pharmacoepidemiology task team, as well as in the immunosuppressed task team. It's great to be with you and to have the opportunity to share as one of the many collaborative groups in immunosuppression. The key question that I and others have been interested in is whether chronic immunosuppression with medications affects inpatient clinical outcomes among adults that have been hospitalized with COVID. And early on in the pandemic, in particular, there was really a tension between, is the immunosuppression perhaps beneficial in that it prevents a hyperinflammatory response, or is immunosuppression perhaps harmful as it's consistently identified as a risk factor for infection? This is something that we looked at using the Johns Hopkins COVID registry. We did not find any statistically significant increase or decrease in risk for people with chronic immunosuppression. But with the limitations endemic to a single site study, we didn't have enough people in order to be able to analyze specific classes of medications themselves, as well as to be able to analyze something outside of just our system. Next slide, please. And so what we're looking at is whether chronic immunosuppressive medication use is associated with clinical outcomes among adults hospitalized with COVID. We're defining chronic immunosuppression as a medication present at the time of admission. So it was started before the date of their admission and it was not stopped before the date of admission. And we're using standard WHO categories of antineoplastic agents and selective immunosuppressants, as well as oral glucocorticoids, and this leads to over 300 drugs of consideration. These are some data from earlier in March, so the numbers will change as the data are finalized and reapproved, but at that time, we were finding 11% of people that were hospitalized were meeting our definition of immunosuppressed, most often with prednisone, tacrolimus, or mycophenolate. The immunosuppressed persons were comparatively older, more often female, and importantly, they were more often receiving medication for chronic disorders like diabetes or pulmonary disorders, and had greater prevalence of individual comorbidities as well. And this is important because when you look at unadjusted results, there is an apparent increase in the risk of both mechanical ventilation and also in-hospital death. But once you use inverse probability of treatment weighting or other advanced techniques to reduce underlying differences in the comorbidities, in the medications, and other baseline factors, we're no longer finding any increased risk of invasive mechanical ventilation or in-hospital death for chronically immunosuppressed adults. We're using multinomial logistic regression with the reference group as people who are discharged alive without any ventilation during hospitalization. And we're using multinomial logistic regression because we were finding a non-trivial amount of the ventilation events had a code that we couldn't use in order to create a time to event analysis, such as respiratory ventilation for 24 to 96 consecutive hours. The next thing we're planning to look at is whether risk varies by the immunosuppressive medication class. And so immunosuppressive drugs is a really large bucket, and they can work in varied ways with different molecular mechanisms of action. And so there might be differential effects on different parts of the immune system, such as some drugs that act via B cell or act via T cell mediated immunity. And so we are considering roughly 15 different drug classes. Some examples include the calcineurin inhibitors for solid organ transplant, TNF inhibitors, most commonly used for autoimmune diseases, and checkpoint inhibitors as anti-neoplastic agents. And we're seeing some of these classes increase risk of ventilation and death, and some of these classes decrease. These results are ongoing, so I'm not going to get into specific details here today. And then lastly, for people who have a history of a solid organ transplant, does continuation or discontinuation of their medications when they're hospitalized affect the risk of outcomes? We're not finding any statistically significant effects, although the point estimates are suggesting that one of the classes of medications being continued and the other class of medications being discontinued might lead to better outcomes specifically for those solid organ transplant patients, such as bacterial infection or an allograft dysfunction. This work reflects the efforts of a broad and diverse group of epidemiologists, biostatisticians, clinicians, informaticians, and content area experts on the team. I'm just one person, but the lucky one to present today. So thanks to all who have been involved in this work and helped move it forwards.
Hi everyone, I'm Kate Fitzgerald. I'm an epidemiologist and statistician at Johns Hopkins, and I lead the multiple sclerosis or MS team. Our MS team is relatively new in comparison to the other subdomain teams, so we're not quite as far along. Similar to some of the other subdomain teams, most cohorts assessing risk and severity of COVID-19 in people with MS are derived from small samples, survey studies with low response rates, or were clinician-entered registries. So we're excited to evaluate these research questions in a more unbiased cohort. Specific goals of our study were to determine if people with MS have a higher incidence of COVID-19 or are at greater risk of more severe COVID-19. We also wanted to determine if MS disease-modifying therapies or DMTs or other symptomatic medications could impact risk or severity of COVID-19. And we'd also like to determine whether certain patient characteristics, demographics, comorbidities, disability severity impact COVID-19 risk or severity. Future research questions we're considering exploring are duration of treatment or MS impact risk or severity of COVID-19. Can we go to the next slide, please? So as Amy previously mentioned, we spent some time defining our cohorts. We used an adapted definition of MS that was validated for administrative data to try to optimize the sensitivity and specificity of identifying the MS cohort. So our approach was relatively similar to what the HIV team, as Dr. Patel had mentioned. And then this flowchart displayed here describes how we identified our cohort. So our final MS cohort included those with at least 2 encounters for MS, individuals with 1 encounter associated with MS, and then use of an MS disease-modifying therapy, or individuals who used an MS-specific disease-modifying therapy. Our final cohort included 9,868 participants. Can we go to the next slide, please? So within the MS cohort, We have nearly 10,000 people with MS, and then within that cohort, 1,731 individuals were identified as having a positive COVID-19 test or having suspected COVID-19. The table on the right displays some of the characteristics of the MS cohort in N3C. On average, participants were around 52 years of age and were around 26% male. The figure on the bottom also displays the distribution of severity of COVID-19 within the COVID-19 positive cohort. 57% of individuals with MS had a mild case of COVID-19, while 23% had a moderate case of COVID-19. Go to the next slide, please. So for our next steps, we're currently completing more detailed descriptive analyses, including breakdown by comorbidity. And then we also hope to move on to multivariable adjusted analyses to be able to complete our aims 1 through 3. Thank you, everyone.
Great, thank you, everyone. Excellent work. So that concludes the ISC group's presentation for today. It looks like we have about 5 minutes, so we can take any questions.
Folks, if you have questions, you can enter them in the chat. Otherwise, you can raise your hand if it's going to be a longer question and we can open your mic. All right, last call for questions. If not, we'll see you again next week.
Thank you, everyone. Excellent work.
Thanks, everyone.
To all of our team members.